Currently at 7, we're going to place that bill on call. We're at item number 10, SB 388, Mitchell Solicitation and Enrollment. Good afternoon, Senator.
Good afternoon, Mr. Chair, and thank you. Let me start by clarifying that we wish to retract our requested amendment that's reflected on page 5 of the analysis, and that's in agreement with committee staff, supporters, and everyone. We got a little ahead of ourselves. Now we're slowing our roll. I'd also like to mention that we are working with the California Association of Health Plans to address clarifications discussed in their letter dated April 15th. So we are in discussion. The summary of benefits and coverage is a vital document that must be provided to consumers by health plans and insurers under the Federal Affordable Care Act and under current California state law. SB 388 will require that the summary of benefits and coverage document is made available in critical threshold languages by geographic area, and clarifies that the SBC must be translated into languages that reflect California's demographics. The SBC, the Summary of Benefits Coverage, details what is covered under a health plan. It explains coverage limitations and provides definitions of key terms to consumers to help them evaluate and compare their health insurance options. Unfortunately, because of a technicality in federal law, health plans are only required to translate this vital document into 4 languages: Spanish, Chinese, Navajo, and Tagalog, 2 of which, well, really 1 of which, aren't completely representative of California's unique and very diverse demographic. 25 of California's 58 counties meet the necessary federal requirements for the SBC to be translated into Spanish. However, there's no similar requirement under federal law to translate other threshold languages in California. This leaves some communities in our state without access to critical information about their health plans, and I believe flies in the face of the intent of the Diamond-Lee-Alatorre Act, which was to guarantee that California-based threshold languages are utilized for critical life-sustaining health services. A recent informal survey conducted by the California Pan-Ethnic Health Network found that only 7 qualified health plans are providing the summary of benefits and coverage in Spanish, even though 9 are required by law to do so. Only 3 out of 5 qualified health plans are providing the document in Vietnamese, and none are providing the document in Korean, even though 1 health plan is required by law to do so. My home county of Los Angeles has 12 threshold languages, which is most of any county in the state of California. This bill will clarify that the document is a vital one under California law. Ensuring that the document is translated into languages that are representative and accessible to members of our diverse California communities is our ultimate responsibility. We must make it abundantly clear that the translation of this vital document must be consistent with California's current language access laws, and this bill will help ensure that all Californians are informed about their health coverage options and have equal access to critical information about their health care. I have several witnesses here with me today, but to start off, Carrie Sanders, Director of Policy Analysis with CPEN, and Katharina New, Vice Chair of the Southeast Asian Resource Action Center.
Thank you. Please proceed. State your name.
Hi, Carrie Sanders with the California Pan-Ethnic Health Network. Thank you for hearing the bill today. CPEN is a proud support and sponsor of SB 388. California's population is one of the most diverse in the country. More than 40% of the population speak a language other than English at home, and an estimated 6 to 7 million, or 1 in 5, speak English less than very well. The Summary of Benefits and Coverage is one of a handful of documents that a consumer views when choosing a health plan. It includes basic information about premiums and copays, as well as a glossary of common insurance terms, which are very important, particularly for communities who are new to the insurance, to having insurance and to these terms. The bill would require the Summary of Benefits and Coverage, which is required under the Affordable Care Act, be translated into non-English languages consistent with California's existing translation requirements for other vital documents. Without this translated information, consumers cannot make informed choices, and in some cases may end up delaying purchasing health coverage and have to pay a fine. Requiring health plans to provide the SBC in California's threshold languages will help consumers make better choices. Here today to talk a little in more detail about this is Sheng Lo, who's a program coordinator with Asian Resources Incorporated in Sacramento, who can testify about the importance of these types of translated consumer materials for certified enrollment counselors like her that are helping limited English proficient community members to enroll.
Good afternoon. My name is Sheng Lo. I am the program coordinator at Asian Resources, a nonprofit community-based organization with 6 offices providing a wide spectrum of social service to the low-income and limited English-speaking youth, immigrant, and refugee community in Sacramento, as well as re-entry clients. We serve and we provide services in Chinese, Vietnamese, Hmong, Mian, Russian, Arabic, Ukrainian, and Spanish, and help ensure help many uninsured community members enroll into Cover California or into Medi-Cal. On behalf of Asian Resources and Asian American Advancing Justice of Los Angeles, Advancing Justice of LA, I'm here today to express my strong support of the SB 388 as a member of a statewide collaborative, the Health Justice Network. We help implement healthcare reform in California. ARI is a subcontractor of the state healthcare marketplace, Cover California, through the lead agency of Advancing Justice of Los Angeles. ARI has been a regional partner of Advancing Justice of LA Outreach and Education Collaborative from 2013 to 2014 in its Navigator Collaborative for 2014 to 2015 and conducts outreach, education, enrollment, post-enrollment, and utilize assistance to help community members about Cover California, medical, and other healthcare programs in Sacramento. So we are very familiar with the cultural and linguistic barriers faced by uninsured individuals, especially limited English proficient persons seeking healthcare coverage, and have seen firsthand the critical need for SB 388. Many limited English proficient and immigrant community members are unfamiliar with the U.S. healthcare system and do not understand some of the healthcare concept and healthcare reform, including the role of managed healthcare plans or healthcare terms used as copay or deductibles. The toughest part of the application process is explaining the healthcare terminology and going over the summary of benefits and coverage to help them choose a plan. For example, although one of the ARI limited English proficient client went through the whole application by themselves, but when she came to the part about selecting a plan, she couldn't understand some of the terms, so she had to come into our office so that we can help her select a plan for her. And after speaking with her for quite a while, she finally understood the basic terminology and could now choose a health plan on her own. So basically, all she needed to do was to understand the basic insurance term in order to be enrolled. So if she had not came to us, she would have missed the deadline to get enrolled. So therefore, to have a translated summary of benefit and coverage like the SB 388 for consumer to have is necessary to make sure that they meet the deadline for coverage and to make the right choice when choosing the health coverage plan. Therefore, ARI and Asian American Advancing Justice of Los Angeles recognize the importance of providing a translated glossary of healthcare term as well as a translated summary of benefit and coverage for consumer, and strongly support the SB 388 and urge the healthcare community to support Senator Mitchell's bill. Thank you.
Thank you very much. If we can proceed, and please state your name and position, if we can make it brief. Anyone else in support?
Hi, my name is Kat. I'm the Vice Chair of the Board for the Southeast Asia Resource Action Center, or CRAC. So we're pleased to support SB 388, authored by Senator Mitchell. This bill ensures that limited English proficient populations are empowered with the knowledge necessary to make informed choices about their healthcare needs by requiring the summary of benefits and coverage to be translated in non-English languages consistent with California's existing language requirements. We are a national nonprofit organization that advances the interests of Cambodian, Laotian, and Vietnamese Americans. The Southeast Asian American community, whose population in California numbers almost 1 million, includes many people who arrived in this country as refugees from Cambodia, Laos, and Vietnam, the largest refugee resettlement in U.S. history. As an organization that supports a statewide network of health partners who directly helps community members access healthcare services, we've consistently heard our partners report that language access is a significant barrier for our communities. While 19% of the overall California population is limited English proficient, that number is even more pronounced in the Southeast Asian American population, with 55% of Vietnamese, 41% of Cambodian, 38% of Hmong and Laotian Americans speaking English with difficulty. Our health partners commonly spend over an hour and a half with one individual just introducing health terminology and concepts in their native language. This is due to the fact that many terms do not have a direct Southeast Asian language translation. For example, one word in English becomes 5 words in the Cambodian language. Co-payment is translated to Jimnai Loi Jingpi Kapao, which literally means your share of money coming out of your pocket. Individuals and families will often return several times with follow-up questions because they are learning to navigate purchasing health insurance without the benefit of a standard written translations, common insurance terms like deductible, premiums, and co-payments. AB 3388
Can we
ensures
ask
that all
you to
Californians-
summarize? There's no
This is my last
opposition.
sentence.
Thank you very much.
We thank the author for introducing the bill, and we urge your aye vote.
Thank you. I'd like just position and name, please, this time. Anyone else?
Beth Capel on behalf of Health Access California and AFSCME in support.
Thank you.
Elizabeth Landsberg with the Western Center on Law and Poverty. We were one of the original co-sponsors of SB 853 that this builds on, and we're in strong support. Thank you.
Michelle Cabrera with SEIU California in strong support.
Sean South with the California Primary Care Association in support.
Thank you. Any questions, comments, or opposition? Is there any opposition? Seeing none. Questions, comments from any of the members? Seeing none, we have a motion by Senator Wolk. Would you like to close?
I ask for your aye vote.
Okay, Chair is recommending to support. Item number 10, SB 388, due pass to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Wen. Hall. Mitchell.
Aye.
Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan.
Aye.
Pan, aye. Roth. Wolk. Wolk, aye.
Currently has 6. We're going to place that bill on call.
Thank you very much.
Okay. Senator Hernandez, SB 243.
Thank you very much, Mr. Chair. Members, as you know, the amount of money the state of California pays providers for a regular fee-for-service primary care visit under the Medi-Cal program is just $16. Just for the sake of comparison, I'm going to give you an example. The large pepperoni pizza at a Round Table will run you around $23. That's more than what a provider gets to see a patient. By next year, we expect more than 12 million individuals in California. About 1/3 of the state will be enrolled in Medi-Cal, and this model is not sustainable. Expanding access to health coverage, as we know, done under the ACA is a significant accomplishment, but in order to truly be revolutionary, and coverage must be accompanied by meaningful access to a provider. Unfortunately, millions of Californians in the Medi-Cal program lack the access because we pay providers an embarrassingly low rate. We currently rank 47th out of 50 states in payments per Medicaid enrollee, ahead of only Florida, Alabama, and Georgia. This will bolster provider participation in the Medi-Cal program, increase access for the underserved, and bring down the hidden costs of health care. And with that, members, I respectfully ask for an aye vote, and I do have individuals here that would like to speak in support of the bill.
Okay.
Thank you, Mr.
Sport, go ahead.
Yeah, thank you, Mr. Chair. Eduardo Martinez with the California Medical Association. I just want to be real brief. I know that the members have heard a lot about this issue. There was a joint hearing on the 4th, which we very much appreciate. Also appreciate the chair's leadership. A couple of data points just to point out there. Recently, the CDC did a study looking at physician participation rates in Medicaid programs. California had the second lowest, only behind New Jersey. It was about 54% participation. They had a direct correlation to the states that pay low provider rates. Secondly, a recent article suggested that a lot of emergency room visits are now moving away from sort of accident-prone presentations to people showing up for chronic conditions that have manifested into emergencies, and those are likely due to not enough primary care, not enough specialty care in the Medi-Cal program. Medicaid beneficiaries were the highest utilizers in that category. So I very much appreciate the chair's leadership on this. We would ask for your yes vote.
Good afternoon, Mr. Chair and members. My name is Sharon Spurgeon, and I represent Kalinga Region Medical Center. I am testifying on behalf of the California Hospital Association in support of SB 243. As the author has stated, SB 243 will rescind the budget cuts made in 2011 to Medi-Cal providers that we refer to as the AB 97 cuts. My hospital skilled nursing facility is deeply impacted by those cuts. Our medical center includes a 99-bed hospital skilled-based nursing facility, which provides essential medical and long-term care services to our community. The next closest facility is within 50 to 75 miles away. If our DP NIF were forced to close or reduce services, residents of our community would be forced to move many miles away from family and friends for medically necessary care. The 2011 cuts were harmful to patients and crippling to hospitals already forced to pinch pennies. Let me give you some perspective relative to our small hospital in Kalinga. Because of the 2011 cuts, the state is now seeking to claw back the difference between 2011 and 2013. For us, it represents $5.1 million or $8,192 a week for the next 11 years, regardless of whether or not we continue to operate. We operate on a very lean budget, and these cuts create an even greater hardship. As compared to freestanding facilities, DP SNFs throughout the state care for patients of greater medical complexity and are often the only option for patients with specialized medical or behavioral needs or for individuals living in rural areas. Medi-Cal beneficiaries make up almost 80% of the patients receiving hospital-based skilled nursing care. Over the past 10 years, many DP SNFs have closed because of financial pressures, and remaining facilities are full to capacity. It is essential that the threat of recoupment be eliminated so that these facilities can continue to operate and meet the needs of the most vulnerable members of our communities. We appreciate the opportunity to speak to you today. Thank you.
Oh, sorry. Thank you, Mr. Chairman. Any other support?
Good afternoon. Dean Chalias with the California Association for Health Services at Home, representing the home health and hospice industry. We're here in support of the bill, appreciate being included in it, and hope as the bill moves its way through the process that some of the waiver programs through which many Medi-Cal beneficiaries receive care from our agencies are included in it as well. Thank you.
Vanessa Hina on behalf of the California Society of Anesthesiologists in proud support.
Lydia Bourne representing American Academy of Pediatrics in support.
Amber King with the Association of California Healthcare Districts in support.
Shay Thomas on behalf of Paramedics Plus in support.
David Ford for the Private Essential Access Community Hospitals, the Alliance of Catholic Healthcare, Adventist Health, Loma Linda University Health, the Association of Northern California Oncologists, and the Medical Oncology Association of Southern California, all in support.
Jody Hicks with the California Academy of Family Physicians in support.
Teresa Stark, Kaiser Permanente in support.
Gary Cooper representing AMN Healthcare and the Oral Surgeons of California in support.
Cindy Hillary on behalf of the 34 rural counties in California in support.
Sawait Sium, Health Access California in support.
Bernadette Ariano from the California Children's Hospital Association in support.
Jennifer Snyder on behalf of the Osteopathic Physicians and Surgeons of California and also the National Association of Chain Drug Stores. And also the National Coalition for Assistive Rehab Technology, which are custom wheelchair providers. And lastly, California Association of Health Facilities for their intermediate care facilities for the developmentally disabled. All of these clients are obviously very much affected by the 10% provider rate cut, so encourage support. Thanks.
Brianna Pittman with the California Dental Association, here in support.
Paul Neprath on behalf of Planned Parenthood Affiliates of California, strong support.
Bill Barcelona, CAP Chief Physicians Group, in support.
Sarah Flox, California Labor Federation, in support.
Dave Kiefer, SEIU UHW, on behalf of the 145,000 members who do healthcare every day, we're in support. Thank you.
Shannon Smith Crowley, representing the American Congress of Obstetricians and Gynecologists in California. We deliver the 250,000 Medi-Cal babies each year.
Wow.
Misty Johnson on behalf of the California Pharmacists Association in support.
Sean South on behalf of the California Primary Care Association in support.
Any other support? Any opposition? Colleagues, any questions or comment? Mr. Chairman, would you like to close?
I respectfully ask for an aye vote, Madam Chair and members, and thank you.
Is there a motion? There's a motion. Please call roll.
Do pass to appropriations. Hernandez.
Aye.
Hernandez, aye. Nguyen.
Aye.
Nguyen, aye. Hall. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk. Wolk, aye.
Thank you. Mr. Chairman, SB 282, please.
Thank you very much, Madam Chair and members. This bill is a follow-up to SB 866, which passed out of this committee in 2011 and was signed into law. The bill streamlined the electronic prior authorization process by establishing a standardized form for prescriptions to use when requesting prior authorization. Since the passage of SB 866, new technologies have been developed that allow electronic prior authorization to be more efficient and less expensive. This bill removes roadblocks to electronic prior authorization by permitting the use of innovative technologies to transmit prior authorizations such as software programs and web portals. This bill requires that new technologies to be consistent with a standardized form and adhere to industry standards. Some physician groups are exempt from using standardized forms because they have internal prior authorization programs within their physicians. This bill clarifies that these groups are exempt from the provisions of the bill, which is consistent with the intent of SB 866. I have individuals who would like to speak in support, and when appropriate, I respectfully ask for an aye vote.
There's no opposition. I'd be glad to move the bill.
Thank you.
Thank you. Melissa Cortez Roth on behalf of Cover My Meds. Cover My Meds is one of those electronic companies that the Senator is speaking of. We work with electronic health record systems, health plans, pharmacy systems, and prescribers to initiate, transmit, and track the status of prior authorizations within the clinical flow. Essentially, what we do is work very carefully with health plans and pharmacy benefit managers to establish the specific criteria for authorization, build that into our electronic systems, and then provide a portal for providers to directly access. This streamlines the prior authorization process. It eliminates the back and forth faxes and phone calls. It essentially saves time and money and gets the patients their medications faster. So we appreciate this bill and ask for your support.
Bill Barcelona with CAPG Physician Groups, introducing our witness, Dr. Karam Arif.
Hi, my name is Dr. Karam Arif. Thank you for having us here. I'm the medical director for managed care at Mercy Medical Group, working with Dignity Health and a pediatrician. We use, as a delegated model physician group, we use internal electronic prior authorization processes that help us speed the prior authorization process for our patients. And so we are in support of this bill. It works well for us, and it'll work well for other folks as well.
Any other support?
Maureen Higgins, representing Express Scripts. We're supportive amended, asking for a clarifying amendment, and on behalf of Biocom in support.
Sean South with the California Primary Care Association in support.
Tom Bone on behalf of CVS Health. We're in support of amended. We're trying to get a clarifying amendment to make sure that programs can talk to one another. We've met with the author staff. We think there's a clarifying amendment that can take care of the problem.
Okay, thank you. Any more support? Any opposition? Colleagues, I know there's a motion. Would you like to close?
Ask for an aye vote, Madam Chair.
Please call for the vote. It's going to be due pass to appropriations.
Hernandez.
Aye.
Hernandez, aye. Nguyen.
Aye.
Nguyen, aye. Hall. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Wolk.
Aye.
Wolk, aye.
We'll leave the row open to allow members to add on.
Thank you very much, Madam
I
Chair.
apologize. We did not do that. I didn't make a comment earlier for the previous vote, so we'll leave that one open as well. Thank you.
Thank you very much, Madam Chair. believe my last item, item SB 586.
Yes, please.
Thank you. This, as we know, this issue was created in 1927. The CCS program provides diagnosis, treatment, and medical case management to 180,000 children with special health care needs who are enrolled in Medi-Cal and low income or have catastrophic medical costs. The program serves the state's most medically fragile pediatric population, including children with conditions like cancer, diabetes, and congenital heart defects. Medical services provided through the CCS program have been historically reimbursed as on a fee-for-service basis rather than through managed care. This has become known as the CCS carve-out. At the end of 2015, the current CCS carve-out will sunset, and the administration has said and has made it very clear that they will not approve another one unless it is accompanied by a plan from and a more organized delivery system. This bill is intended to be the starting point in the discussion to develop that system. This bill will allow CCS providers to form systems to integrated primary care with specialty care and treat the whole child, not just a CCS eligible condition. Specifically, the bill creates regional kids integrated delivery systems anchored by the CCS tertiary hospital or by a CCS provider in partnership with a CCS tertiary hospital. Under the bill, these kids networks would provide a patient and family-centered health home for children with eligibility conditions. The state would contract with Kids Network beginning in 2018. As a transition, the carve-out would be extended until 2018 and maintained subsequently for populations that cannot access the Kids Network or for whom inclusion in such network is appropriate. This bill extends the CCS carve-out, preserves the CCS standards of care, and creates networks responsible for providing or coordinating all medical care services to CCS children through a patient-centered medical home. Finally, the bill requires providers to work collaboratively with each other families in order to ensure children continue to receive access to the highest quality care. I have a set of amendments in mock-up form that have been distributed to the sergeants. These amendments are in response to concerns raised by the Hospital Association and others and are intended to allow additional providers with appropriate expertise to form kids networks. And I have some individuals like to speak in support of the measure, and I respectfully ask for an aye vote at the appropriate time, Madam Chair and members.
Thank you. Support witnesses, please.
Madam Chair, members, my name is Ann Coons, and I'm the President and CEO of the California Children's Hospital Association. CCHA is sponsoring SB 586 in an effort to both to preserve what works about the California Children's Services Program and to respond to the strongly stated desire on the part of the Department of Health Care Services to improve the integration of primary and specialty care services for medically fragile children served by the program. The goals of this bill are threefold. First, to improve the coordination of all the healthcare services provided to these medically complex children. Second, to maintain access to the regionalized system of pediatric specialty care that benefits all children with special healthcare needs in this state, not just children who are eligible for CCS. And third, to keep faith with the children and families that we are privileged to serve by providing opportunities for family involvement and establishing a reasonable time frame for reforms. I'm happy to answer any questions, and I'd ask for an aye vote.
Good afternoon, Madam Chair and Committee. Jenna Jensen, Chief Government Relations Officer with CHOC Children's. We're a health system in Orange County serving children. We have 2 children's hospitals, one in Orange, one in Mission Viejo, 4 community clinics, and a variety of specialty health centers. So I just wanted to share with you that this bill will provide the opportunity for providers who really understand children with complex and chronic conditions, those who have the expertise, experience, and resources to meet the needs of that population to really lead in advancing their care. And I think when we look for solutions to advance the delivery of healthcare and really move the state of the art in medicine ahead, that we need to understand that revolution is really going to start on the provider side, because this is where the relationships are, this is where the care occurs, and it's really where we need to start. So this bill will allow the folks that have that expertise and experience to really take a leadership role in advancing the care for these fragile populations, and I'd ask for your aye vote. Thank you.
Madam Chair and members, Tim Shannon representing the Children's Specialty Care Coalition. Also with me to answer any questions you might have of our association is Aaron Kelly, our Executive Director. Our coalition represents nearly 2,000 pediatric subspecialists that treat the sickest kids in California, those with the CCS conditions. It was formed in 1998, and your committee analysis mentions that there have been over a half dozen extensions of the CCS carve-out since 1994. We sponsored about 5 or 6 of those. Dr. Pan was the latest author that we had, but we realize now that it is time to, instead of kicking that can down the road another time, really deal seriously with the issue of providing an integrated system. The Children's Hospital Association, who we worked with over the years, approached us conceptually for a program which they now call the KIDS program. We think it's a wonderful idea. We think that it's something that can garner administration support. We're very hopeful that you will approve it today and that it can move on and that we won't have to keep, as I say, extending the carve-out. We think the carve-out is very important, that the kids that are in the CCS program really need subspecialty care and they need the providers that the CCS program impanels. But I think it's time to move to another paradigm. So we do urge your aye vote. Thank you.
Any further support?
Yes, Madam Chair and members, Terry Calgar-Hill on behalf of the California WIC Association and Children's Hospital Oakland. Both of my clients are in strong support of this measure, and we urge your aye vote.
Good afternoon, Angela Blanchard on behalf of the March of Dimes here in support.
David Ford on behalf of Lucille Packard Children's Hospital in support.
Bill Barcelona, CAP Chief Physician Groups in support.
Barbara Glazer on behalf of the California Hospital Association. We're supportive of the bill moving forward today. There are some issues that need to be resolved among our hospitals, but the hospitals are committed to reaching consensus, and we urge your aye vote.
Mr. Chair and members, Trent Smith on behalf of CalOptima, the Medi-Cal Managed Care Plan in Orange County, here to echo some of the comments made by our partners, the Children's Hospital of Orange County. Look forward to the bill moving forward and continuing to have discussions with the author and interested parties to preserve the unique relationship that we currently have with our Children's Hospital. Thank you.
Margaret Johnson with Disability Rights California. We are in support of amended, and we have been working with the author's office on amendments to correct our concerns. Thank you.
Elizabeth Landsberg with the Western Center on Law and Poverty, support of the bill in print with one requested tweak and still looking at the mock-up to make sure there's sufficient network adequacy. Thank you.
Kevin Pedrati representing Together We Grow, a respite care organization, in support of the bill.
Tom Bunn on behalf of Sutter Health. We are in support of the bill moving forward. We know there are a lot of moving parts. We've been engaged as part of the process. We encourage the bill to be moved forward today.
I'm a bit of a tweener, but I'll go now. Teresa Stark with Kaiser Permanente. We did have some concerns with the bill in print. The amendments that are being put forward today go a long way to address our concerns with the bill. We really appreciate the process with the sponsor and others. The conversations that have been going on to address our concerns have been very helpful. We were concerned about the bill's impact on our children. We are a CCS provider. We do care for the whole child and are proud of our CCS providers and the care they provide. So we want to continue to do that. And again, really appreciate the process and look forward to continuing to work with the author and the sponsor in hopes that we'll be able to completely remove our opposition down the line. Thank you.
Good afternoon. I'm Jennifer Gabals with the California Association of Health Plans. We also have some concerns with the bill, and some of those have been addressed in the mock-up that we received today, and we appreciate the sponsors and the author and his staff for working with us to address our concerns. We still have some concerns, though, in regards to paneling of new providers. We'd like to see something in the bill that would increase access to address the backlog that currently exists to make the network a little bit more substantial and local. And so again, we will continue to work with you to address those concerns. We appreciate your hard work. Thank you.
Any more opposition? Or
Thank you, Madam Chair. Eduardo Martinez with the California Medical Association. We have an opposed unless amended position on the bill.
Really want to commend the author and particularly the sponsors for really sort of spending so much time about the future of the CCS program. A lot of the goals we share about treating the whole child and make sure that there's a continuity of care, fragmentation of care, all goals that we generally support. Regrettably, the Department of Healthcare Services has not fully complied with the statutory requirement to undergo various pilot projects about different models of delivering care to this population. We were hoping to look at some of the data from those pilots to inform us about what our position should be on CCS program, the CCS program going forward. Since those were not undertaken fully or somewhere in the process, we're sort of left in this sort of weird space here. Not only that, there is a current sort of stakeholder process that the department is convening right now, which purportedly is going to result in a proposal from the administration sometime this summer. We think at the very minimum that that stakeholder process should play itself out. So we're opposed unless submitted, but happy to keep talking with the author and other stakeholders moving forward.
Lydia Bourne, representing American Academy of Pediatrics. First, I'd like to thank the sponsors for meeting with us, attempting to address our concerns. However, we were unable to reach a solution. As noted, the Department of Healthcare Services has a very robust stakeholder advisory council, which the pediatricians are very actively involved in. And so we believe that this process may be a little premature. We're waiting for recommendations from the stakeholder advisory group as well as from the specific data coming from the pilot projects. This is a very complex system. When it's been in existence for a long period of time, receives very high marks, and we believe we need to be very cautious in terms of making any comprehensive changes. And so for these reasons, without the recommendations as well as the data from the pilot projects, we remain opposed. However, we will continue to be working with the sponsor as well as with the author. Thank you.
Any more opposition? Colleagues, Dr. Pan?
Well, I want to, first of all, thank the author, our chair, and the Children's Hospital Association for putting a proposal forward. We do need to look at the future of CCS. As a CCS provider, and also someone, and also as noted earlier, the author of the previous carve-out bill, and actually even someone who, before I was in the legislature, served on the federal work group on access to pediatric subspecialty care. CCS is a unique program in the country, and it does need updating and modernization. That's why I appreciate what both Senator Hernandez and the Children's Hospital Association is proposing. Clearly, it's a program that focuses on some of the most vulnerable, the sickest, our patients who are most complex. And I understand that there are ongoing discussions, as mentioned by previous witnesses. At this point in time, I certainly want to see this discussion continue to move forward, and I will be voting for the bill so that they can continue. But I'm also looking forward to how this evolves and more final versions of the bill as more discussions are taking place. There are I think some issues with the current model, but I know that we've had conversations with the Children's Hospital Association and others, and hopefully we will get to the place where we will actually improve the CCS program and also be sure that we provide high-quality care for these children who really need really specialized care. So I want to thank, again, the author and the sponsors for this bill. Thank you.
Senator Mitchell?
Thank you. I was curious. CCS is a critical program. It's always a little makes you a little nervous when you have to go through the process of getting the sunset removed temporarily. So it's currently due, the carve-out is due to sunset in 2015, but there was some mention about some work groups, some stakeholder work groups, and I wonder what's the time frame for that work to be done?
I'm happy to answer that.
Okay, sure.
I serve on that work group too.
Okay, great.
So the last Stakeholder Advisory Board meeting, I think, is May 29th. And then I think the department is planning to come forward with their own recommendations based on the feedback from those work groups and the activities going on. There's a bunch of sub-work groups too. And I understand that the department is hoping to have some sort of proposal that they're going to be putting forward in June or July. I think the issue is that the sunset is in December. So if we don't have language that we can work on and conceptually kind of agreement about what we as the providers to see these kids would like to see, we're going to be, I think,
that's kinda
far
late,
behind. It's
right.
late in the process for us to all be kind of getting together and
And so
vetting
the
it.
administration would potentially then, so it would be after the current budget cycle, so the administration would be putting forth legislation? What's their vision?
Not clear.
Unknown.
Yeah,
Thank you
yeah.
very much.
Any other comments? I want to, then I'll make just a few comments. I want to thank our chairman for putting this forward. This is a very complex, I mean, these children are very fragile. It's very important that we have a place and be able to move them in where we need to when the administration cuts off the sunset or when the sunset sets. I will be supportive today, but I also have been in discussion with CHOC of Orange County and also with CalOptima, and I understand that there's going to be a work in progress in terms of coordinating and working together, because I was there when Healthy Families moved into CalOptima. I was there when behavioral health was forced and autism was moved into CalOptima as a CalOptima board member, and it was not fun. And so I want to make sure that all the partners, especially in Orange County, where I represent mostly, and where these children actually lives, is that there's coordination, and that as we move forward, there's more discussion, and that hopefully once this all sets in, it's going to be a smooth ride across the state. So thank you. Would you like to close, Mr. Chairman?
Yes, I would. And we all agree that this is a very vulnerable population. But most importantly, it's for individuals or parents who don't have the resources to be able to give these most vulnerable children the services. So we understand that there's a lot of work to be done, but keep in mind, I think this is the legislature's ability to have that conversation, as opposed to when we had to deal with it like Healthy Families through the budget without a policy hearing. Right. We're going to be going through policy in the assembly, on the floor. We're going to be interacting with the administration. They're going to be coming forward with their proposal as well. But I think this is an opportunity for us in the Senate to kind of shape what we want and how we want to see this. Whether it's another one-year extension or not, but the time has come, and obviously the administration definitely wants to stop the reauthorization of it. But anyway, with that, members, I respectfully ask for an aye vote.
Thank you. If there's a motion,
Move the bill.
please call for the vote, and this is due pass as amended to appropriations.
Hernandez.
Aye.
Hernandez, aye. Wynn.
Aye.
Wynn, aye. Hall. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, aye. Pan.
Aye.
Pan, aye. Roth. Roth, aye. Wolk. Wolk, aye.
Passes to 8-0 as amended to appropriation. And, yeah, the bill, yeah.
That bill is out. We're going to go ahead very quickly. We know we have members that have to leave and have a meeting. We're going to start at the top. If we can start with item number 1, SB 26. This is due pass to judiciary. Current vote count is 5-0. Call the absent members.
Wynn. Hall. Mitchell. Mitchell, aye. Roth. Roth, aye.
That is 7-0. Item number 3, SB 145, Pan, due pass to judiciary. Current vote count is 5-1. Call the absent members.
Wynn. Wynn, no. Hall. Wolk.
Current vote count is 5-2. That bill is out. Item number 4, SB 149, Stone, due pass to BNP. Current vote count is 4-0. Call the absent members.
Wynn. Wynn, aye. Hall. Mitchell. Mitchell, aye. Monning. Roth. Roth, aye. Out.
Current vote count is 7-0. That bill is out. Item number 6, SB 243, Hernandez, due pass to appropriations. Current vote count is 7-0. Call the absent members.
Hall. Roth. Roth, aye.
Current vote count is 8-0. That bill is out. Item number 7, SB 282, Hernandez, due pass to appropriations. Current vote count is 7-0. Call the absent members.
Hall. Roth. Roth, aye.
8-0. That bill is out. Item number 8, SB 291, Laura, current vote count is 6-0. Call the absent members.
Hall. Mitchell. Mitchell, aye. Nielsen.
Current vote count is 7-0. That bill is out. Item number 11, SB 435, due pass to appropriations, Pan. Current vote count is 6-1. Call the absent members.
Nguyen? Nguyen, aye. Hall? 7-1.
Current vote count is 7-1. That bill is out. Item number 12, SB 546, Leno, due pass to, as amended to appropriations. Current vote count is 4-1. Call the absent members.
Nguyen? No. Nguyen, no. Hall? Monning? Aye. Monning, aye. Roth? 5-2.
That current vote count is 5-2. That bill is out. Item number 14, SB 610, Pan, due pass as amended to appropriations. Current vote count is 7-0. Call the absent members.
Nguyen? Nguyen, aye. Hall?
Current vote count is 8-0. That bill is out. We now have the consent calendar. Item number 10. Well, we have item number 10, SB 388, Mitchell. Current vote count is 6-0. Call the absent members.
Nguyen? Aye. Nguyen, aye. Hall? Roth?
388.
Roth, aye. 8-0.
Current vote count 0 is 8-0. That bill is out. We have the consent calendar. That's item number 2, SB 65 Woke. Item number 15, SB 746 Woke. Current vote count is 5-0. Call the absent members.
Nguyen? Aye. Nguyen, aye. Hall? Mitchell? Aye. Mitchell, aye. Roth? Roth, aye. 8.
Current vote count is 8-0. Those two bills are out. And the business of the day is concluded, and we are adjourned.